This video wraps up Chapter 28 of OEC 6, looking at altitude-related emergencies. And really what we want to focus on in this case is the management, the treatment of a patient with either AMS, HAPE, or HACE. For the management of a patient, we really have to consider two things. Deal with life threats, generally supportive in nature, and make sure that they go down. Lower altitude is key. Depending on the severity of symptoms, that descent may have to be done very quickly. So for general management, initial treatment, as always, begins with checking the ABCDs, placing the patient into a position of comfort, and possibly being supportive with high flow oxygen via a non-rebreather mask. You can check that with a pulse oximeter. Keep the patient warm as needed with jackets, blankets, etc., because what that's going to do is eliminate any cold stress, which can elevate pulmonary pressures by vasoconstriction in some of the distal extremities. That's going to make it worse for them. Realize that these patients present with nausea, and so anticipate vomiting and be ready to clear the airway and suction the airway as needed. We'll monitor vital signs and prepare them for transport, because if it's HAPE or HACE, they're going to require further evaluation and treatment. Treatment of AMS, acute mountain sickness, really centers on treating the symptoms, ensuring that they don't go higher, and waiting for the acclimatization to occur and improve their conditions. They can help this by minimizing their exertion, and it's possible that high flow oxygen can be beneficial in treating symptoms such as headache and nausea. The other treatments are going to be symptom-based. For headache, the patient may choose to use Tylenol or ibuprofen. If the symptoms do not resolve, it's important that the patient goes to a lower altitude. For pulmonary edema, if oxygen is scarce or unavailable, it's important that we rapidly take the patient to a lower altitude, up to 3,000 feet lower than the elevation where the symptoms were first observed. Unless there's no other way, avoid self-evacuation, because the exertion of that physical activity can really increase respiratory demands and make this worse. Transport the patient in a sitting position to support their respirations, and delivery of oxygen is going to be critical for this patient as well. If oxygen is available, then the descent could be delayed a little bit for rescuer safety, because that oxygen is going to reduce some of the pulmonary arterial blood pressure that's the root cause of the swelling, the edema in the lungs. In severe cases, such as at Everest Base Camp, you may see a specialized device, such as a Gamow bag. And a Gamow bag is basically a portable hyperbaric chamber. Following evacuation to a lower altitude, patients should be transported to the hospital for further evaluation and treatment, and they may be prescribed medications that reduce pulmonary blood pressure. Upon release from the hospital, they can slowly ramp up their physical exertion and realize it's going to take possibly a couple of weeks to recover completely. For high altitude cerebral edema, at the first sign of ataxia, the umbles, mumbles, bumbles, and stumbles, or a change in their mental status and responsiveness, patients should be transported to a lower altitude, 1,500 to 3,000 feet below. High flow oxygen will be supportive as well, and if descent is not possible, again, a portable hyperbaric chamber such as a Gamow bag can buy you some time until descent is possible. Patients should be transported immediately to a hospital for definitive evaluation and treatment, and steroids that reduce inflammation will assist in reducing the cerebral swelling, the cerebral edema that's occurring. In all cases, a lot of our treatment is going to be symptomatic and followed by rapid transport to a lower altitude. That's really going to allow these patients to recover.